All right, party people. Today, we're going to be going over how to deal with a question if the USMLE presents to you a liver that has yellow deposits on it found on autopsy after an elderly person was complaining of left lower quadrant pain, fever, and tachycardia. Before we get into the funky liver, let's first deal with the left lower quadrant pain, fever, and tachycardia that this patient was experiencing prior to death. If USMLE gives you an old dude complaining of left lower quadrant pain, fever, and tachycardia, just know that they're talking about diverticulitis. This is not to be confused with diverticulosis. Diverticulosis is very common. About 50% of the people over 60 in the US have it. And all a diverticula is an outpouching of your GI tract without inflammation. When one of those diverticula becomes inflamed, then it's diverticulitis. And for fun fact, bonus points, the most common location is the sigmoid colon. Now, getting back to the funky liver, the yellow liver coating is fibrin. Why is it fibrin? It's due to the inflammatory process in the peritoneal cavity. Inflammation triggers neutrophils, macrophages, cytokines, and chemokines, leading to deposition of fibrin. Another way the USMLE can test this is with Fitzhugh-Curtis syndrome. That's where a young woman with pelvic inflammatory disease develops perihepatitis. The infection spreads to the liver capsule. If she dies, an autopsy may show the same kind of yellowish coating. Again, this would be fibrin. So although this might seem like a strange question or something like that you don't need to know about, they do ask it. This is also connected to surgical knowledge. Fibrous adhesions in the peritoneal cavity are the most common cause of small bowel obstruction. These adhesions usually result from prior surgeries, like C-section or laparotomies. Patients can present months or years later with small bowel obstruction, symptoms such as high-pitched bowel sounds, which would equate to a partial obstruction, or obstipation. And obstipation is a fancy way of saying no stool or gas, but a complete obstruction. So these adhesions are made of fibrin, the same material from the inflammatory process like diverticulitis or pelvic inflammatory disease. Some other distractors that they might hit you with would be dermatan sulfate and heparan sulfate. Note, heparin is the drug. Heparan is a glycosaminoglycan, and this is a component of the extracellular matrix. While they're involved in tissue structure, they're not what you see in deposits on the liver capsule during acute peritonitis or inflammation. Quick overview of type 1 collagen, because I've seen people mix this up. So type 1 collagen is mainly found in bone. It's also involved in late wound healing, usually after 6 weeks, giving the tissue a whitish appearance due to the higher tensile strength. Another option they might present to you is type 3 collagen. This is found in early wound healing. It appears pink. It's also found in blood vessels, especially in the aorta. So a key USMLE question to associate with type 3 collagen would be Ehlers-Danlos syndrome, which involves a mutation in type 3 collagen and can cause aortic dissection or Barry aneurysms. So just a quick recap regarding fibrin on the liver capsule. It can be seen in any of the conditions involving peritoneal inflammation, such as diverticulitis, Fitzhugh-Curtis, and post-surgical adhesions leading to small bowel obstruction. All right, that's it for this one. Go crush it.